We're going to talk about 4 common dementia syndromes, and I always try and think, how do I start this? And I always have to lean on history and clinical experience, so we'll head that way. But first, a story. So you heard about the elderly couple that went to see their primary care doctor for their annual physical exam. And this time, the gentleman went first, and the doctor conducted a very thorough physical, and he said, "You look to be in excellent health. Do you have any particular concerns for me?" And the elderly gentleman said, "Well, doctor, as a matter of fact, I do." He goes, "The first time that I have sex with my wife, I'm usually cold and chilly afterward. And then the second time that I have sex with her, I'm hot and sweaty. What is that?" And the doctor said, I'm not sure. I'm puzzled, but let me examine your wife next and we'll sort it out." So the doctor proceeds to her exam. She's in excellent physical health. He informs her that, and he says, "By the way, your husband had an unusual complaint." He said that the first time that you have relations, he's cold and chilly, and that the second time you have relations, he's hot and sweaty. Can you help me understand that? And the wife just laughed, and she said, "That crazy old coot. The first time is in January, and the second time is in August." Okay. So the moral of that story is we have to be specific, don't we? We have to understand things fully. Otherwise, we're prone to make assumptions. So I remember vividly being an Air Force psychiatrist in the mid to late 1990s at Wilford Hall Medical Center here in San Antonio, Texas. And in came a wonderful Hispanic family with the patriarch, their father, their grandfather, and he had problems with memory and problems with recognition and problems with day-to-day life. He could no longer drive. He'd easily get lost, even though he'd lived all his life in San Antonio. He'd been a very competent, hardworking guy. Couldn't recognize any of his family members. Needed a lot of assistance in all domains. And of course, in the mid to late 90s, we did what we had at hand, technology-wise. I think we probably did a CT scan, and we obtained lots of blood work, and we came up with nothing. And back in those days, I made the grand diagnosis, not of dementia, not of Alzheimer's dementia or Lewy Body dementia or vascular dementia, but I made the diagnosis of organic brain syndrome. And back in those days, we had no medicines except a kind of an experimental, mystical medicine called hydrogene, which purportedly dilated blood vessels in the brain and increased blood flow diffusely in the brain. And we prescribed it, and it was completely ineffective. I guess the good news is it wasn't toxic. And you know, when I think about that, that wasn't that long ago. Wasn't that long ago. So here we are, 20 plus years later, and we've come a mighty long way, because the most common question that I get asked by family members and staff people is, "What's the difference, Dr. Weiss, between dementia and Alzheimer's dementia?" And, you know, we'll begin this presentation with sort of an umbrella. So dementia is a global definition for a progressive neurocognitive disorder. Just like pneumonia is an umbrella term for an infection of the lung. But of course there are different types of pneumonia. We have bacterial pneumonia, viral pneumonia, fungal pneumonia. And each of those types of pneumonia has a different course, symptomatically, a different treatment. And that's the good news. and we can diagnose them precisely, and we can target therapy precisely. So we're going to talk about 4 common syndromes of dementia, and we're going to talk about simply history, physical exam, and testing as guidelines, nothing more than that. And each of these syndromes, I'll have a 1-paragraph case example, and then we'll expand on it. Now, I'm going to beg your grace immediately, because this is a presentation that I had to create for a group of physicians in hospice. So I've got a lot of abbreviations and a lot of medical terminology, and I'll do my level best to define things and spell them out, but I may stumble a time or two. So these 4 syndromes, at least as of 2014, we think they account for 90% of all cases of dementia after, keyword, we exclude the reversible causes of cognitive impairment. You say, what are the reversible causes? So, metabolic deficiencies, vitamin B12 or folate deficiencies, thyroid disorder, okay, an infectious disorder like tertiary neurosyphilis, things that we can treat with an antibiotic or vitamin replacement or thyroid replacement. Those are, quote, reversible, if you will. So the 4 syndromes are as follows, and please notice the abbreviations because I'll use them a lot. So Alzheimer's Dementia, AD, Vascular Dementia, VAD, Dementia with Lewy Bodies, DLB, and then Frontotemporal Dementia, FTD. They're not the florist, okay, FTD, Frontotemporal Dementia. So those are 4. And here's the good news. We only have 16 slides, okay? So it's short, sweet, but the slides are dense. So we'll start, we always going to start every piece with a little case so you can kind of see the patient, if you will. So here's a 70-year-old gentleman. And I'll just add, in excellent physical health, kind of like our gentleman in our little story. And he appears now, of course, how he appears, did the family drag him in? In all likelihood, yes. Probably the adult children, perhaps his spouse. But he presents with a 3-year history of progressive memory loss. So it hasn't been going on a little while. It's been going on a while. And it's primarily, I have STM, short-term memory. His long-term memories are pretty well preserved. Okay? So, God bless him. He needs his daughter to help him out quite a bit. Remind him of appointments and ADLs, activities of daily living. He's having more and more and worse problems driving alone. And he's becoming confused with routes and destinations that you would think are automatic. Okay? His bills are in disarray. And as the daughter probably discovers, for months on end. And his physical exam is completely unremarkable. One of the mysteries of Alzheimer's dementia. Here's a good heart, good lungs, no diabetes, no kidney disease. All systems go physically, but serious illness is upon him. And then there's the mini mental status exam. This is a tool, not a very specific tool, but a quick and easily used tool that kind of gives us a snapshot. It's not diagnostic, it's just a screen. We think anything less than 25 on 30 is suggestive of impairment. We think 17 to 24 is mild impairment, 10 to 17 is moderate, less than 10 is severe. So he has, quote, mild impairment by the mini mental status exam. So the message here is a memory disorder, eh? So we know a lot about Alzheimer's disease, but not enough yet. Much more to come, much more to be learned. Maybe it'll be an endless learning session. I hope so, because that's a good thing. So Alzheimer's dementia is still thought to be the most common dementing illness in adults older than 65. That's a foot stomper pearl, okay? All right? Probably many pathways to this disease, many pathways. You know, we know that there are misfolded proteins, senile plaques. Those are beta amyloid proteins. Neurofibrillary tangles. These are tau proteins. We also know there's mechanisms of inflammation, of oxidative damage to the mitochondria, the little energy fuel cells in our neurons. So just a host of vectors that cause damage and destruction. In a very general way, from diagnosis to death, this is a long march, 8 to 12 years. Although, certainly can be quicker, certainly can be longer, but in general, 8 to 12 years. And the hallmark, right at the center of this, is memory decline, memory deterioration. Primarily short-term memory goes from less and less to little to none. And then we start to see changes in long-term memory. Its onset is insidious, kind of like Carl Sandburg in his poem The Fog. It creeps in on little cat feet, okay? Its course is sort of relentless, but slow, okay? It's not abrupt. And, there is the kind of the central feature. There must be impairment either in language, in recognition, in movement, or in executive function. You say, what the heck's executive function? Well, you did it today driving to work. Executive function is planning, okay? Executing mid-course corrections, multitasking. You're driving, hitting the radio station, and looking at the stoplight, okay? All that is executive function, sequencing, okay? Language, so, loss of words. Give me that whatchamacallit. Mr. Flabeats, what's this? Well, that's something on your wrist, okay? Recognition, put a quarter in the palm of your hand. What is that? No idea. Praxis, I use the example. I was flying last week. I get offended when the attendant tells me how to put on the seatbelt until I realize internally that can be a Herculean task for somebody with severe Alzheimer's dementia. And then the second to last bullet, embrace this. Motor symptoms, in other words, how the patient moves, are usually absent. So when I see a new patient, I meet him in my waiting room, and it's probably 50 paces to my office, and they have to make a left-hand turn, and I watch them come up the first part of the L, and I watch them come down the first part of the L, and I look at their gait, okay? And I'm looking for any change in motor movement, no arm swing, rigidity, a limp, what are called petit pas, little tiny steps, okay? So motor signs are absent early in the course. Now later in the course, particularly with debilitation, that may change. And then the behavioral changes, this is a foot stamp or two, they start to appear in the mid to late stages. So timing is everything, just like our joke, January and August. Timing is everything. Now, we're going to use Alzheimer's dementia as our template to compare and contrast the other three types of dementia. That's going to be our game plan. So, vascular dementia. Now, I'm going to highlight early on in our little patient vignette the differences. So, number one, a 65-year-old man, so he's right on that cusp, isn't he? Age cusp. But this guy has got some chronic illnesses. Remember, our Alzheimer's patient, healthy as a horse. This poor soul has hypertension, diabetes mellitus, and coronary artery disease. And, God bless him, 6 months ago, he had what looked like perhaps a stroke or a TIA. A left hemiparesis means the left side of his body was weak, not paralyzed, but weak. And dysarthria means he could speak, but the language was difficult to understand. Okay? So he had some type of neurological event. So he has some significant illnesses, had a neurological event 6 months ago, and 3 months after that, his wife said he doesn't know his only 2 grandchildren, who he dearly loves. And he's forgetting to take his medicine. I've noticed this. At first I thought it was just a single episode, but it's all the time. Nor can he operate a remote control, and he's a sports fan. He's operated it like a wizard for decades, okay? And he can't cook simple meals. And when you examine him, remember our Alzheimer's patient, his physical exam was cold, stone normal. He has a pronator drift. What's a pronator drift? Mr. Flavice, stand with your feet together, close your eyes, put your hands out. That's a pronator drift. Weakness on the left side. Can't keep his hands up. Pronator drift. And he's hyperreflexic. I tap his reflexes. Chung! I don't even need a hammer. I use my finger. Hyperreflexic. Okay. So we know there's been some type of neurological insult, if you will. This is vascular dementia. Okay. Now, there's a multitude of variations on vascular dementia. I won't torture you. There's multi-infarct, single infarct, lacunar infarcts, genetic forms, hypoxic encephalopathy, people that decide to carbon monoxide themselves and have a loss of oxygen to the brain, have a vascular type of dementia. So many different pathways toward it. But what's common is they have motor signs, okay? And they have focal deficits when you do a neurological exam. And they don't necessarily have memory impairment, but what they have early and profound is executive function. Can't operate the remote control. Early on, okay? Can't do those things. So let's compare and contrast. I love this because it always reminds me of the 4th grade. The nuns would always say, all right, kids, now compare and contrast the gross national product of Venezuela with Bolivia. Remember, it glued the little coffee bean on there and the little piece of tin. I have this vivid memory. So compare and contrast. So off to the left, clinical symptoms. We'll zoom down and I'll translate. In the middle is vascular dementia. On the far right is our template, Alzheimer's dementia, the most common dementia. So number 1, a history of ASCVD, atherosclerotic coronary vascular disease. I can only say that once a day. Yes, patients with vascular dementia typically have a history of long uncontrolled hypertension or maybe poorly controlled hypertension, diabetes, they've had a heart attack or 3, they've had a TIA, a transient ischemic attack, kind of a brief short-lived stroke, or a CVA, a cerebral vascular accident, a stroke. And Alzheimer's dementia, it's not impossible, but it's usually very rare. So right away, just in the taking of the history, you kind of get a tip-off. This way, that way, okay? But you want to build your case, all right? What's the onset? Well, you got the picture with Alzheimer's dementia. Generally speaking, Alzheimer's dementia is gradual and insidious, kind of like a glacier moving, right? With vascular dementia, it can be gradual, but quite often it can be sudden. Let's go back to our gentleman here. Okay, so he has a stroke-like event, and then 3 months later, bang, doesn't remember the names of his grandchildren, okay? Neurological exam, he's got deficits, the drift, the hyperreflexia. Usually it's normal in the Alzheimer's patient. The gait, if we were to watch him walk carefully, heel to toe, backward heel to toe, walk on your heels, walk on your tiptoes, we'd probably see some problems, maybe stumble a bit. Memory, so, the sine qua non for Alzheimer's dementia is memory impairment that progresses. Here, it's usually kind of mild, okay, usually kind of mild. But executive function, early, it's dreadful. In Alzheimer's disease, it gets dreadful, but that's later. And you say, okay, we've suddenly moved to the Norwegian countries. What's a Hachinsky score? So in Alzheimer's research nowadays, when we are screening patients for candidates for dementia studies, we do a Hachinsky score. So this is 8 different questions for the patient and their caregiver that have to do with risk factors for vascular dementia. And typically, if they score more than 4, they are excluded from Alzheimer's dementia studies because they probably have vascular dementia primary. You say, well, I'm glad you guys do that. And we're glad too, because the early studies with Alzheimer's dementia in the late 90s and the early 2000s, we didn't do this. So the fact of the matter is we probably had patients in those studies that had vascular dementia and Alzheimer's dementia. Is it possible to have both? You bet. Possible to have both, okay? And then lastly, if you image them, you'll probably see some signs, maybe an infarct, okay, which is a dead space, if you will, in brain tissue, or damage in white matter. You're not going to see much, if anything, in Alzheimer's dementia unless you do a quantitative age-matched controls where they zero in on the hippocampus and they actually look at right, left, and total volumes of the hippocampus, and you'll see shrinkage in Alzheimer's patients. So different locations, different focus of damage. So, dementia with Lewy bodies, a horse of yet again a different color. So, 72-year-old man with a 6-month history of cognitive impairment, so it hasn't been going on a long time, and visual hallucinations. Well, wait a second, this isn't Alzheimer's, this is psychiatric. He's seeing things. Presented to the emergency room after repeated falls. His wife said he'd been slow in thinking, speaking, and performing his routine activities for a few months, short-lived again, okay? On exam, he's rigid. His gait is Parkinsonian-like, moving slow, and he has masked faces. Looks like wooden Indian, expressionless, stone-faced all the time, okay? Because he can't move the muscles in his face. This is a motor illness. And he's not taken any medicines to account for this, okay? In fact, he's pretty healthy. He's been pretty healthy, okay? So right away, what happens to somebody like this? Whistle up psychiatry. Why? Because in this history, the one thing that leaps off the page is visual hallucinations. He's seeing things. So he's crazy until proven otherwise. Forget all this other rich, complex, excellent history. We're just whistling up the psychiatrist. So typically what happens? Maybe there isn't any psychiatrist. This is a rural area, and the primary care doctor, God bless them, they are the heavy lifters and the hard workers. They say, well, seeing things, I'm going to give you an antipsychotic. And lo and behold, he gives them an antipsychotic. And now the patient goes absolutely berserk, because these patients have incredible sensitivity to antipsychotics. So, a bad situation has now gotten worse. This is 3 Mile Island, Chernobyl, however you want to view it. But, wait, hope is on the front here, okay? So, dementia with Lewy bodies. So, this is an interesting dementia because it's currently defined as having core symptoms and then sort of associated features that kind of help the cause here. So the core symptoms are fluctuating cognition. One day good, one day bad. It fluctuates. Attention fluctuates. So it's not consistent like Alzheimer's dementia. Okay? Visual hallucinations. Usually these are stereotyped. I see a green frog in my right upper quadrant. It's right there. Which is very odd. They're usually very stereotyped. It's always the same thing all the time. Okay? And then Parkinsonian. These folks move slow, talk slow, stone-faced. They're very rigid. You think, oh my God, you have Parkinson's disease. But there's no history of that per se. And then secondary features, lots and lots of falls. Because they drop out. They have faints, okay? They're incredibly sensitive to antipsychotics. They can start to have delusions. Other hallucinations, kinesthetic hallucinations, like they feel like they're moving and they're not, okay? REM sleep disorder. So here's where the partner, the spouse, are going to give rich history. I've been sleeping with him for 60 years, but the last 3 or 4 months he's crying out, he's having these vivid dreams, he's striking at me, and then he's okay for a while. And then usually they can look profoundly depressed. So a different picture yet again. And this is all just history and examination. We're not calling in imaging studies or anything else. Okay? So let's compare and contrast to our template on the right, dementia of Lewy body disease. So number one, unlike a demented Alzheimer's patient who's going to move rather fluidly and fluently and have some, smiling and frowning and some changes in expression, these folks are going to look more like a Parkinson's patient. They're going to have psychiatric symptoms of some type, usual visual hallucinations, very early on. Their mental status is going to wax and wane quite a bit. In Alzheimer's patients, we're not going to see that wax and wane unless they're delirious, okay? Verbal memory is pretty good with these folks, okay? Not so with Alzheimer's patients. Memory impairment, so you say, uh-oh, what do we got here? Semantic and episodic memory. So semantic memory is memory for ideas and meanings and connections, okay? Episodic memory is events and experiences day to day, okay? So that's where you see impairment. They have more trouble with meaning and ideas. They can tell you sort of what happened that morning, if you will, okay? Executive function, it's dreadful, kind of like our vascular dementia people early on, less so in Alzheimer's. Lots of impairment in attention and construction. So these folks are going to have a heck of a time in the mini mental status exam drawing intersecting pentagons. Same thing with vascular dementia people and clock drawing. Okay. So autonomic, you say, what is that? So the autonomic nervous system, that part of our wonderful wiring system that is constantly sending signals and monitoring where we're at in time and space and keeping us upright. So we'll see changes in terms of autonomic dysregulation. So these folks can have big changes in their blood pressure and pulse. And actually that's a typo. Please forgive me. That should be far less common for Alzheimer's dementia. So I stand before you contrite. And then neuroleptic response, we need to move that last sentence down a bit. As I said before, they're exquisitely sensitive to antipsychotics, with one exception, two exceptions. They do okay with Seroquel and Clozaril. Okay? Alzheimer's patients that are behaviorally disinhibited, they usually don't get worse. They might get sedated, but they don't get more agitated. Now, you say, well, it sounds a lot like Parkinson's disease dementia. And there's an overlap, if you will. We haven't quite parsed it out, but in the middle is dementia of Lewy Body disease, and on the right is Parkinson's disease dementia. And just some fine points that separate them. You're far less likely to see that tremor that's so classic in Parkinson's disease and Lewy Body. Okay. Also, Parkinson's disease usually starts with motor symptoms unilaterally. This will have it bilaterally. Okay. These folks are much more likely to be fainting out, less so with Parkinson's disease. Okay. And then at time of diagnosis, usually folks with the dementia of Parkinson's disease, they've had a diagnosis of Parkinson's disease, primarily motor symptoms, for at least 2 years before they have the dementia. So it comes later on, okay? Both of them don't do terribly well with, increasing dopamine. You have to treat them with other measures. And then the cognitive impairment in Lewy Body precedes more motor symptoms, where it comes after motor symptoms in Parkinson's disease dementia. I know this is a lot to digest, but these are going to be little tables that you can have at hand, okay? And then, biblically, the last shall be first. Maybe this is first primarily from a dramatic presentation, although you might say visual hallucinations. A little green frog in your left upper quadrant is pretty dramatic, but wait, I'll take it up a notch. So here's a 50-year-old gal, young, right away. You say, wait, this can't be dementia. She's 50. She's a puppy, okay? And she's got behavioral changes. And it hasn't been just a little episode here and a little episode there. It's been going on 2 years. And she'd been a good worker, a worker bee, but now all of a sudden, heck with that. And she doesn't even finish her task, okay? And she's eating. In fact, she even ate half my sandwich when I was sitting there. She just grabbed it, okay? She eats things that people don't eat, okay? I saw her take some out of the garbage can, for God's sake. And she's had a rapid weight gain. And you know, she's always been a very prim, proper, circumspect gal, but now she lies. She's telling vulgar stories. And I saw her stealing stuff. And she's picking up objects, just picking them up and putting them down and picking them up. There doesn't seem any purpose to it, you know. Putting some in her mouth. Hyperorality, okay. Her hygiene, she'd always been very, very impeccable, and now it's going downhill fast, and she's not bathing. So the only thing that we see on her physical these are called primitive reflexes, a palmo-mental and a grasp reflex. So you stroke their chin, you see a twitch, okay? You run across their hand and they grasp it. These are primitive reflexes that should not be there, okay? That's all she's got. And her mini mental status, look at that. She's acing it. 29 out of 30, except when you ask her to do the clock drawing test, it's all over the place. She kept putting the pencil in her mouth. She tried to eat the piece of paper. So very dramatic, very bizarre. And what do most clinicians say? Whistle up psychiatry, okay? This is a lady having a midlife crisis. She's got some kind of atypical depression. She has a personality disorder. Maybe she's a substance abuser, you know. But this isn't dementia. Look at her age, okay? So, prominent personality and behavior changes early on. This is the red flag, the flashing yellow light at the railroad crossing out in the country. And like I said, it's usually misdiagnosed more than once, okay? And you might really not find anything on physical exam, but maybe primitive reflexes. So let's compare and contrast this to Alzheimer's dementia. So number one, these folks are young. You'll hardly ever see FTD in somebody over 75. Usually the median age, I think, is 58. Okay. Behavioral problems, that's it out of the gate. Very common. As opposed to, maybe I shouldn't have written unusual, but late, you know, and usually in the mid to severe stages. This is early on. Very inappropriate, very disinhibited. Why is that? Well, our frontal lobes are our brakes, B-R-A-K-E-S. They're what makes us stop at the red light at 2 in the morning when there isn't any traffic around and we're in a hurry. We inhibit, okay? They're our consciences, if you will. So their memories usually aren't impaired early on, whereas that's the hallmark in Alzheimer's dementia. Now, language problems. So I'm cheating here. There's actually 6 variants of FTD. The one that we're describing here is the most common. It's called the behavioral variant. There are 2 other variants, the semantic variant and primary progressive aphasia, that's PPA. And these are really unique because when these patients present, they do great in everything except they can't name a thing. Just can't name a thing. So they kind of confuse clinicians, right? Pretty rare. Visual spatial defects, these are rare, common in Alzheimer's dementia. Motor signs, more so than Alzheimer's dementia, but not like you'll see in vascular dementia or in Lewy Body. Their mood. So alexithymia, what a great word from the Greek, meaning absence of emotion. So these people aren't flat. They're flatter than flat. They're emotionless. They have no empathy for you or for themselves. Okay? And And that can be quite problematic, because here they are doing all these things out in society, and people are appalled. Okay. Psychotic features, they're generally different from Alzheimer's patients, that have the paranoid persecutory piece when they develop it. Usually these are bizarre, or they're religious or jealous, but they're usually rare. And then there's the other kicker. They become very oral people. Especially they crave carbohydrates. They put lots of things in their mouth, kind of like a little kid, a little infant who's experiencing the world, okay? And what do we see in Alzheimer's dementia as it progresses? The other side of the coin. People stop eating, they lose their appetite, they don't have any taste. It's difficult. So, I was trying to think about, I don't want to show you this one yet. How do we sum all this up? So I like one-word summary. So Alzheimer's dementia, memory impairment, okay? Vascular dementia, plumbing problem, okay? A flow problem, blood flow. We've got infarcts, plumbing problem. Dementia of Lewy body, motor symptoms, one word, motor, okay? And then FTD, personality changes. So, I'm a lumper and a splitter all at the same time. So if you got to walk away with something, it's going to be Alzheimer's dementia, memory, okay? Vascular dementia, plumbing problem. Think about plumbing, blood flow, vascular. I'm pausing it. Frontal or dementia of Lewy body. Dementia of Lewy bodies, we're going to think about motor symptomatology, and lastly, frontotemporal dementia, bizarre personality changes. So, at the risk of shocking you into insensibility, but maybe the value of this is like that Virginia Slims ad, we've come a long way, baby. So, in the 1920s? Thank you, Nina. I was going to say 30s. Frontal lobotomies were done in the thousands, the tens of thousands in this country and in Europe. And here's a picture of one of the most famous practitioners. And please notice the sterile operating conditions and the advanced techniques, okay? And of course, there are the doctors in training appearing very curious, and there's the lovely nurses assisting the doctor as he taps a very long needle through the puncta, and then, as you can see in the bottom radiograph, sweeps the frontal lobe. And this was not only a recognized, but an applauded technique in the world, because it took patients who were agitated and now made them docile. And that's why that book and that movie, One Flew Over the Cuckoo's Nest, is so emotional, because McMurphy, who is such a trouble to the administration at his psychiatric unit, doesn't respond to ECT, so finally they do a frontal lobotomy, and he now becomes a non-person, but not a trouble, okay? So you say, why did you put that in there? So the frontal lobes, they're a big part of who we are and how we behave. And even small damage can have huge repercussions. Yet at one time we even treated people with this. Now it strikes us as barbaric, but at one time it was celebrated. So, in conclusion, you're probably saying, why did he have to show me this today? I just don't be thinking about that all day. That image is going to resonate. I apologize. Okay, so in conclusion, if we don't sort these syndromes out, then we risk misdiagnosing and mistreating and miseducating the patient and their family. Okay, and just like pneumonias, different types of dementia require different treatments and different management. And I didn't talk about any of that today. We're just kind of getting to the tip of the iceberg. And right now, the four common dementias come to mind just from the history. You already get you get kind of clued up as to where we're going, and then you want to fine-tune it down the way. Doesn't necessarily mean we're locked in, okay, but kind of helps us sort it out. And then we always must embrace this. And I don't know who said this, but, you know, this is medicine in its finest, and maybe more than medicine, maybe just how we treat each other is, you know, hopefully we can cure sometimes, and more often we can relieve symptoms, but we can always care for people. So even in the worst situation, terminal illness, we can provide care. And thanks.